Assalamu alaikum. Can you hear me, guys?
Yes, clear, very clear.
Thank you very much. Good morning, good afternoon, and good evening, everyone. Thank you, Dr. Naveed, Dr. Masood Umar, and Dr. Umar Bhatt, brother, for your invitation. Nice talks all around, and I've been given the most difficult task to somehow save the meniscus while doing your ACL reconstruction. I have nothing to disclose, and so I have nothing to disclose. Let me start off by saying why you should save the meniscus. We all know about the anatomy of the meniscus. It is wedge shaped, the blood supply is well established, and we know it performs a lot of important functions in the knee, like load transmission, shock absorption, joint stability, lubrication and nutrition, and proprioception. But the most important one is the load transmission. What it does is that it turns the axial load coming from femur onto tibia into a circumferential hoop stresses. So if you see, look at the picture on the right, you see the first picture where the meniscus is present and the load is evenly distributed. But when the meniscus is not there, the load increases tremendously onto the articular cartilage, causing the wear and tear and damage and leading to osteoarthritis. So this was published by Barrett in 1986, again, another biomechanical study. So if we do a partial meniscectomy, 65% of the weight is increased. And if you do a total meniscectomy, the transmission at the peak contact pressure increases almost 235%. And you can see it on your left with the truck, with a heavy body, with two tires. If you, that's the weight is evenly distributed, there's less wear and tear with the tires, but if you remove one tire, the stress is more on a small surface area and there's more stress and more wear. So which compartment takes more weight? The lateral compartment and the lateral meniscus, which carries almost 70% of the load in the lateral compartment, and that's because of the convexity that results in greater tendency towards peak loading. So it means that if you do a lateral meniscectomy, you end up with something like this. In 4 or 5 years down the line, the patient will start developing arthritis and the pain. So meniscal repair is not something new we are talking about today. It's been there and well established in 1980s by the father of the meniscal repair. We call him Dr. Charles. He invented and introduced the world to the inside-out technique, the perimeniscal abrasion techniques, and the fibrin clot. But unfortunately, meniscectomy is still the most commonly performed arthroscopic procedures globally. I don't know why. I'm guilty, maybe I'm one of them who used to do that as well. So what we have learned from the historical perspective, this was the first study that came out in 1948, and they said that perhaps the meniscectomy can cause the ridge formation, narrowing of the joint line, and the flattening of the femoral condyle, but he couldn't really establish the link between the meniscectomy and the occurrence or happening of the arthritis. So what we needed is the long-term studies that could really establish the fact that the meniscectomy is harmful for the knee joint and its biomechanics. So we looked at this paper published in 2004. They did a follow-up, 21 years follow-up after meniscectomy, and they suggested that 71% of the knees did develop a mild, but alarmingly, 48% knees had more advanced arthritic changes. We looked at another paper, and this is published in 2016, almost 20 to 30-year follow-up. 3 out of 4 patients had developed radiographic tibiofemoral osteoarthritis, and 1 out of 4 had developed patellofemoral arthritis. So yes, now we have the reason. We know the meniscectomy can cause arthritis. The more problematic are the ones who are in their peak prime working years, like the age group between 30 and 45. And now, because we are more concentrated on preserving the meniscus, we have better investigation to identify those lesions, and we have better repairing techniques to preserve those. So the next question is, what can we say? We know the common types of the meniscus. We know the blood supply of the meniscus. We know there is a red zone, the red-white zone, and white zone. So anything that falls in the red zone is bound to heal. Red and white, we are still not sure, but we are hoping that it will heal. And white zone is still a dilemma for us. But having said that, we need to look at the incidence of meniscal tear with ACL injury. So we know ACL is a traumatic injury. Any tear of the ACL is a traumatic. So what percentage of the knees will have the meniscal tear? So this was the paper published 2015, almost 80% knees. More seen in patients who were left for more than 2 months. The incidence of meniscal tears were more, probably perhaps the wear and tear or the abrasion, and that may have caused it, not sure. So now we know that 80% of the knees with ACL tear will have meniscal tear. So where exactly it is? It's in the peripheral 1/3, more common in the peripheral 1/3. Good news, it means the peripheral 1/3 has a better blood supply, so we can save it. We should try and save those meniscus. Okay, so the next thing is, where is the located? Is it anterior or posterior? Anterior would be a lot easier, not required much of the learning curve, but unfortunately, the more meniscal tears associated with ACL injury lies posterior. So it means there's a steep learning curve, and you need to be careful, because when you're repairing those meniscus, you're very close to the neurovascular bundle, and there are reports suggesting the nerve injury and arterial injury with the meniscal repair. So you have to be careful. So with all this, we have the indications now. We can treat the acute tears, peripherally located, well-vascularized zones, and which are longitudinal, vertical in orientation. And we have extended our indication to the horizontal cleavage tears, the root tears, the ramp lesions, and the radial tears, and the tears in the red-white zone. However, we are still struggling with the tears in the avascular area. So if you're going into the OR and you're planning for a meniscal tear, you should be aware or well versed with all the techniques. You should have all the armamentarium in your OR tray, so you can do, if possible, the inside out or the outside in, or all inside in techniques, whatever is available. And if there's nothing available, just remember, do not remove it, because removing will cause more problem. So if you remove it, what about the healing rate? This is the trial conducted by the Moon Group, which is the multi-center orthopedic outcome network. And they said that doesn't matter what kind of material you want to use, the healing rate is almost in the region of 95%, because remember, most of the tears are in the peripheral 1/3. So if they are in the peripheral 1/3, they are in the red zone. So no matter what you use, you will get it healed. We still have a problem though with the avascular tears in the avascular area, and that's what the future we're looking at. The orthobiologics, they're looking at the PRP augmentations, the bone marrow aspirates, and there's still trial going on for the PRP for the meniscal repair. The orthobiologists, maybe they'll have a role. Another thing they're looking at by the help of biomedical engineers, clinicians, and industry leaders to develop a meniscal implant. So that's everything is in pipeline. So hopefully in near future, we will have more things available to save the meniscus. So we have come a long way from the slogan raised by Smiley in 1967 to take it all out from saving the meniscus. Thank you.